In June, Dr. Peter Shabad will be, who's also a local analyst at the Chicago Psychoanalytic Institute, will talk about seizing the vital moment in psychotherapy and psychoanalysis. Um, we're working on July it to be a live Colleagues and Conversations, and there'll be more about that coming forward. In August, we'll be lucky enough to have Dr. Charles Jaffe, who's also a local psychoanalyst, talking about a paper he just published that it's collaboration between him and a research team that addressed the question of what exactly goes on in the at an operational level in the conversation that we call psychotherapy. So I think we have a really exciting lineup ahead of us. And at the end of February, Yellowbrick will also make a presentation about emerging adulthood and um, some of what we have learned about embracing Gen Z and working with Gen Z and their unique clinical struggles or clinical challenges. We'll be talking about that for the Vermont Psychological Association, and we're sending information about that out, so you're free to register for that if you'd like. Okay, without further ado, I want to introduce Dr. Levinson, who is a professor in the Department of Psychological and Brain Sciences and in the Department of Pediatrics at the University of Louisville, and she's the director of the Eating Anxiety Treatment Lab there. She's also the founder of the Louisville Center for Eating Disorders, which is the only eating disorder specialty clinic in the state of Kentucky, where she treats patients and supervises and trains other clinicians and students in evidence-based treatments for eating disorders. She is currently vice chair of the Kentucky Eating Disorder Council, which is a state-sponsored council charged with improving the treatment of eating disorders. Dr. Levinson's research, and I think we'll all find this really helpful and useful, her research focuses on building new treatments for eating disorders, primarily using new technologies. To do this, she uses advanced analytics and technologies such as individual network analysis, ecological momentary assessment, and wearable sensor technologies. Dr. Levinson has been the primary investigator on several national grants and awards, including 4 active clinical trials testing exposure therapy and personalized treatments for eating disorders. She has received several awards for her work, including the Academy of Eating Disorders in 2015 Outstanding Scientific Contribution Award. Before returning to her home in Louisville, Dr. Levinson trained at the University of North Carolina Center for Excellence in Eating Disorders, where she trained in cognitive behavioral therapies, dialectical behavior therapy, family-based therapy for adolescents with anorexia, acceptance and commitment therapies, and mindfulness therapies for eating disorders. She completed her clinical internship at the University of North Carolina School of Medicine and received her master's and doctoral degrees in psychology at Washington University in St. Louis. And she did her undergraduate work at the University of Kentucky. So without further ado, welcome, Dr. Levinson.
Well, thank you. I'm glad to be here and excited to talk about our work. All right. So these are my disclosures. Just a brief outline of what we're going to be talking about today. I'm going to introduce you to the eating disorders and tell you about why my team is calling the eating disorders a silent epidemic. We're going to just talk briefly about what eating disorders are and how we treat eating disorders currently, although I know that most of you are familiar with this stuff, but just a brief refresh on that. And then I'm going to talk about the 3 problems with current eating disorder treatment and what we're doing to solve those problems. As was mentioned, feel free if you have a question to put it in the chat or shout it out. Used to having questions kind of as we go, but you're also welcome to save those questions for the end as well. Okay, so eating disorders have the second highest mortality rate of any psychiatric illness, so only after opioid use disorders. 2.8 million Americans will have an eating disorder in their lifetime, and these rates are unfortunately growing. Um, Most eating disorders are often undetected, and they cost the United States about $64.7 billion in 2018. And this is an economic costs only. If you add on well-being costs, we're looking at around a $400 billion cost of well-being and economic loss just in the United States and just in 1 year. So eating disorders are not a small problem. I always like to show this figure here. These are data from Kentucky, where I live. They are epidemiological data collected from 11 to 13-year-olds. And what you can see here is that just under 50% of 11 to 13-year-olds are trying to lose weight. And if you happen to know any 11 to 13-year-olds, they really should not be trying to lose weight. And we also know that dieting is the #1 risk factor for development of an eating disorder. You can see we've also got pretty high percentages in terms of 20% are fasting, about 6% are vomiting and taking laxatives. This is 11 to 13-year-olds. Actually, my colleague shared with me today some of our newest data, and I think it was something like 48% of young adults in Kentucky met for a restrictive eating disorder, which is just kind of wild. So the point in showing this figure, and it is just to point out, and you all, I may be preaching to the choir here, but eating disorders are really common. They're getting more common, and they're starting to impact people at younger and younger ages. So we really need to have something to treat these illnesses. Okay, so what are eating disorders? Again, I know a lot of this will be a review, but just to make sure we're all on the same page here, there's several different types of eating disorders. So probably the eating disorder that people hear the most about is anorexia nervosa. And this is difficulty maintaining appropriate body weight for height, age, and stature. And accompanied by this is this intense fear of gaining weight or becoming fat. Bulimia nervosa is another common eating disorder, and in this eating disorder, there's also those fears of gaining weight and overvaluation of weight and shape. But it's also accompanied by binge eating episodes and then some sort of compensatory behavior in response to those binge eating episodes. And this can be anything from vomiting, laxatives use to things like excessive exercise. Binge eating disorder is this similar to bulimia nervosa, except that there are none of these compensatory behaviors. And binge eating disorder is really often very common. It's equally prevalent among men and women, so really something to keep your eye out for. Avoidant restrictive food intaker is a newer eating disorder, and you can really think about this as kind of extremely picky eating. And I'm happy to answer questions about RFID if anybody has those now or at the end. And then finally, other specified feeding eating disorder. This is the one I really want to talk about because most people don't realize that other specified feeding and eating disorder, OSFED, and I really feel like we could come up with a better name than this, but it is what it is any type of eating disorder that doesn't fall into one of those other categories. And this is things like atypical AN, which is very similar to AN, except the person is not classified as underweight. And this is actually the most common eating disorders. So most eating disorders that we see are OSFED, and OSFED is usually as severe, both medically and psychologically, as other eating disorders. So it's not something that we want to discount or not think about. So actually 50% of eating disorders out there are going to fall into OSFED. Okay, so how do we usually treat eating disorders? And this is important background information for what I'm going to be talking about in a little bit, because we really want to think about how treatment actually exists currently, to think about how we can improve those treatments move the science behind treatment along. So most treatments for eating disorders are delivered in outpatient settings. And there's several different types of evidence-based outpatient treatments. So there's cognitive behavioral therapy enhanced. There is family-based treatment for adolescents with anorexia nervosa, and more recently they've expanded it to bulimia nervosa and binge eating disorder. There's also dialectical behavior therapy, interpersonal therapy, acceptance and commitment therapy. So lots of different options for outpatient therapy. But perhaps the most supportive form of outpatient therapy is what is called eating disorder specialty treatment. And this is where you have a team of medical and therapeutic professionals. So you usually have a therapist, a dietitian, a prescriber, and a medical provider who are highly trained in eating disorder treatment, working together to help treat the eating disorder. And this can be in outpatient or at higher level of care. So as I mentioned, eating disorder specialty treatment can be used in outpatient. It can also be used in higher levels of care, because oftentimes eating disorders are really severe and outpatient just is not enough. So there's different types of higher levels of care, and the highest level of care is inpatient care, which is 24/7 medical stabilization. And the goal of inpatient eating disorder care is really just to get the person medically stable. So make sure they have proper nutrition, that their lab work is stable, that they're not going to die, right? Keeping in mind that, as I mentioned, these are very deadly illnesses. So moving down from inpatient care, we have residential eating disorder treatment, and this is 24/7 care, around the clock care for eating disorders. Usually it is in a private facility, in a home or something like that. Patients generally usually have to be medically stable at this point, but their eating disorder is severe enough that they really are not ready to go back to outpatient or to be out in the community. Partial hospital programming is a step down from residential, and this can be anywhere from 6 to 13 hours a day for 5 to 7 days a week. And intensive outpatient is 3 hours a day, 3 to 5 days a week. So there's lots of different options for eating disorder treatment, depending on how severe the eating disorder is. And usually in these settings, you would have providers giving eating disorder specialty care, which would be kind of a mixture of the different types of evidence-based treatments with medical care, dietetics, meal support, and lots of different types of interventions. So any questions on just eating disorders in general and what treatment looks like currently before we move on? All right, I'll take that as it was super clear. Everybody knows what's happening. Ready to go on to the next part. Okay, so what I'm going to talk about now are the 3 problems with current eating disorder treatment and what my team and I are trying to do to solve those problems. So problem number 1 is that treatments do not work forever. What do I mean by that? So evidence-based treatments only work in about 50% of individuals with eating disorders. And this is even with highly trained clinicians and standardized trials. So this is if you look at cognitive behavior therapy enhanced, you look at eating disorder specialty care, you look at FBT for adolescents, you've got about a 1 out of 2 chance that this treatment is going to work. There's no evidence-based treatments for underweight adults with anorexia nervosa. So, if you go to look up what are the evidence-based treatments for eating disorders, there is not anything for underweight adult AN or for OSFED, keeping in mind that OSFED is the most common eating disorder out there. So to me, this is unacceptable. 1 in 2 people that come in, we're not going to get them better. And that's just not okay. So we need to do something to move the needle and make these treatments work for everyone. So we have to ask ourselves, well, okay, so these treatments don't work. Why aren't treatments working? And what we know is that there's extremely high heterogeneity in the eating disorders. So even within the same diagnosis, participants present to treatment extremely different. I mean, I think as a clinician, you know this, right? Your patient comes in, every patient is different, even if they're coming in with what the DSM would classify as the same disorder. So we want to kind of think about how treatments or how evidence-based treatments are developed, right? And usually when we're developing an evidence-based treatment, we're developing that treatment based on average. So we've taken this whole group of eating disorder patients, and we know that on average, they all struggle with body dissatisfaction or overvaluation of weight and shape. So we're going to base our treatment on that. But what happens when a patient is different from average? There isn't really a solution for that. And so what happens in treatment is that clinicians often use guesswork to decide how to personalize treatment, right? Because those evidence-based treatments don't tell you how to deal with a patient who is really struggling with food insecurity or who has really extremely high social anxiety. And the problem with relying on clinician judgment is that we know from lots and lots of data is that if you compare clinician judgment to more evidence-based standardized database processes of decision making, that clinician judgment ends up not performing as well and can be very biased based on what the person is trained in or what they're working on, et cetera, et cetera. So even within diagnoses, so we know that even within similar diagnoses, symptom profiles look extremely different. We know that most people meet for other specified feeding and eating disorders. We also know that large numbers of individuals migrate among diagnostic categories. So you might have somebody that has anorexia nervosa, and then they migrate to bulimia nervosa. And this really makes it difficult to pinpoint what to target in treatment. And it also makes it difficult to apply these on average treatments that aren't accounting for differences within people with eating disorders. My team has been working on this problem for a while, and what we've been finding is that there's growing data that show that about 50% of patients with eating disorders have weight and shape concerns as the biggest problem that they're dealing with, but the other 50% don't. So again, what that means is that our evidence-based treatments might work really well for these 50% of patients that share that as as their major problem, but it's not going to work as well for the 50% that that's not the primary concern. So what we wanted to do was figure out how we could use evidence-based methods to take guesswork out of treatment and to instead use data to personalize treatment. So our solution for the past, 8 years now, 8 or 9 years, 9 years, we've been working to use data to personalize treatment. And I'm going to tell you all a little bit about what we're doing in this area. So how do we do this? Ooh. We got slides on repeat somehow. Okay, here we go. Okay, so I'm going to give a brief primer on network theory and analysis, so bear with me. This is a lot of math, but it's math that hopefully I can break down enough to be understandable. Okay, so how does the field currently conceptualize eating disorders? So as I mentioned, the primary treatment in the eating disorders is cognitive behavioral therapy enhanced. And this model, which can be translated to many different ways of thinking about psychopathology, you have what are called core beliefs, and these core beliefs lead to cognitions, so things like I am fat, which lead to emotions like anxiety, which might lead to physiology like increased gastric sensations, which then might lead to food restriction, All of this that is a dynamic cycle happening where people are experiencing cognitions, emotions, behavior, and physiology that is maintaining the eating disorder. So what network analysis is a form of mathematical model that allows for a characterization of a large amount of symptoms and relations among symptoms. So instead of identifying latent variables, which is how the field of psychology has traditionally kind of thought about underlying diseases, instead, what network theory and analysis does is it thinks about how do symptoms of an illness maintain the illness. And we think about pathways among symptoms as partial correlations and central symptoms, or the most important symptoms, as centrality. Now, importantly to this model, in network theory, central symptoms are theorized to be treatment targets that impact the most other symptoms in the overall network. And I'm going to show you what I'm talking about here. So this is a traditional latent variable model in the first model, which in a latent variable model, we would say that bulimia nervosa is causing overvaluation of weight and shape, binge eating, and compensatory behaviors. So the eating disorder is actually causing the symptoms. In a conceptual network model, we would instead think that symptoms are causing other symptoms and interacting with other symptoms, and that is what is causing the disorder to maintain itself. So, for example, I've restricted my food, and so that causes me to binge eat, which then makes me feel guilty, which then makes me purge, and then the cycle continues. And then in C, we have a similar model for one person, which is what we call an idiographic model. Okay, so going back to that model I was talking about, we have, if we're going to put this in eating disorder terms, we have the cognition or the thought, I am fat, which leads to restriction, which leads to anxiety. And all of this is kind of stemming from the core belief of overvaluation of weight and shape, or what we would call in network analysis a central symptom. And the pathways between symptoms we would call illness pathways. So again, here what we have is we have our cognitive behavior therapy model, and we have our network model, and you can see that they're really pretty similar. Any questions here? All right. Okay. So we've talked a little bit about network theory and network analysis and how network theory conceptualizes how eating disorders maintain themselves. But what does this have to do with being able to personalize treatment, to be able to actually address all that individual heterogeneity that we know happens in the eating disorders? Well, the really cool thing about this type of model is that you can actually model it for one person. So for many, many years in psychology, everything we really did was we want to get really large sample sizes and look across all of these different individuals and try and figure out what's going on in a huge group of people. But what we do here is we actually get a whole lot of data from one person, and we use an idiographic network model, and we can figure out what the person's eating disorder or any other type of disorder looks like for that one person. And you can think about this like case conceptualization. This is how we conceptualize patients, clients when they come in, but instead we're using data to do this. So I'm going to show you what this looks like. So this is some of our now earlier work at this point. And this is one participant, and this is their network model. And what we're looking for are the most central symptoms. So for this person, their most central symptom is dieting, notated with that big green dot there. And so in this model, we would say that participants' intervention should target dieting. This is participant number 2. And what you can see is that for this person, it's excessive exercise and binge eating that seem to really be most central. And so in this intervention, and so for this person, we really want to work on disrupting binge eating and excessive exercise. So this is a third participant. This person's most central symptoms were restriction and overeating, and so we would target restriction and overeating. Okay, so our next question was, all right, well, first we figured out that we could model these, we could model symptoms in people with eating disorders, and all their models look pretty different, right? Some people had overlap, but in general, we had a lot of evidence that they were heterogeneous, but that wasn't really anything new. I mean, we know that eating disorders are heterogeneous, and now we're just showing this with their individual network models. So what we wanted to know was, well, can we actually use this to treat people with eating disorders? Because it's one thing to talk about it and play with data, but as I mentioned, people are dying from eating disorders. So every 52 minutes, somebody dies from an eating disorder. By the time I'm done giving this talk, someone will have passed from an eating disorder. And so we really need to stop messing around and figure some things out that work. My team started developing what we're calling transdiagnostic network-informed personalized treatment for eating disorders. And I'm going to tell you a little bit about the development of this and some of the outcomes on this. So our first question was really just, can we apply this method in treatment? So we recruited individuals with any eating disorder, and we personalized treatment based on their idiographic network. So how did we exactly do this? So the first thing we did was we created a comprehensive assessment of eating disorder symptoms and comorbid disorders. So we went into the literature, we talked to lots of clinicians, and we developed an assessment that had any sort of symptom or mechanism of or co-occurring disorder that had any clinical or research-based evidence as a potential maintenance factor for eating disorders. So something that would need to be treated in treatment. And then a priori, we decided which treatment we would match to these symptoms using the literature. And I'll talk about what that looks like in a bit. So then participants completed 15 days of ecological momentary assessment 5 times per day. So it looks like this picture of the phone here on the left, where patients are asked about their symptoms and they respond. And then we take that data and we use that to create an idiographic network. And then we match patients based on their own idiographic network. Our final N was 79. This was the procedure of the study. So patients completed a diagnostic assessment. They then did baseline measures. They did EMA for 15 days. After their model was run, we did 3 to 4 sessions on their first central symptom. They completed mid-study measures. We then did 3 to 4 sessions on their second central symptoms. They did post-treatment measures and then follow-up measures. So what did treatment actually look like? Session 1 was diagnosis and assessment. Sessions 2 to 3 were psychoeducation. Session 4 was personalized treatment psychoeducation, and then sessions 5 to 9 were personalized treatment on their top 2 central targets, and then session 10 was inclusion and relapse planning. And then we've got an example over here of what some of our psychoeducation looked like, and you can see here, for example, if Anne's most central symptoms were guilt and anxiety, she would be matched to do dialectical behavior therapy module on guilt, and CBT for anxiety. Okay, so what did we find? So first, we identified 24 different treatment targets out of all the targets that we assessed. So you can see here on the left some of the most common treatment targets that we identified. So things like body dissatisfaction, shame and guilt, drive for thinness, worry, depression. And interestingly, most symptoms were cognitive affective in nature. And I say this is interesting because traditional evidence-based treatments for eating disorders tend to rely on behavioral interventions and really focusing on the behaviors. But we've actually found, and now this has been replicated in several additional studies, that from a symptom perspective, it tends to be the cognitive affective symptoms that are really driving the eating disorder. So I'm going to show you some examples of what this looked like for individual patients. So this is a patient with anorexia nervosa binge purge type, and her most central symptoms were binge eating and impulsivity. So for binge eating, she did interventions, she did food logging and regular eating. And for impulsivity, we did DBT, distress tolerance skills. This is a patient with bulimia nervosa. Her two top central symptoms were shame and sadness. So she did opposite action for shame and behavioral activation for sadness. This third patient had bulimia nervosa, and her top two most central symptoms were hunger anxiety. So we did mindful eating, and self-criticism. We did self-compassion treatment. This is just a big list of all of the different symptoms and what symptoms are matched to in terms of evidence-based treatments. So you can see things like worry. We did mindfulness for worry. For fear of weight gain, we would do imaginal exposure. For high standards, we would do perfectionism treatment. And then these are the affect physiological symptoms and comorbid conditions. So lots of different things that we were assessing, and people are really different, and the different types of treatment they got varied a lot, is essentially what I'm showing here. Okay, so moving into what we actually found about the treatment. So as I mentioned, this was a open series trial. So the first thing we were really interested in was feasibility and acceptability, because when we started this, we had no idea if people would do this treatment, if the models would run, if they would stick with it, if they would like it, et cetera, et cetera. We recruited 79 people, 75 started treatment. 62 completed all 10 sessions, so about 83%, and 66, so about 88% completed at least 5 sessions. For anybody who does clinical trial research or who does research in the eating disorders, what will stand out about this is that these are really strong retention rates. So if you look in the literature, it's usually pretty good if you get about 50% of people with an eating disorder to remain in a clinical trial. So the next question is, well, what about completing all of the surveys that we use to run the models? Would people complete them? And the answer here is yes. We had about a median 75% compliance rate on the pre-treatment EMA surveys. So most people were completing a relatively high amount of surveys. 100% of our models converged. And then in terms of acceptability, we had pretty high ratings. You see here, quality of treatment was 5.15. So in general, I was actually pretty happy with this. People seem to like treatment and stick with it. Okay, so what about the outcome data? Okay, so this is our initial efficacy with eating disorder symptoms, and what you can see here is that eating disorder severity decreases from pre-treatment to post-treatment and continues to decrease up to 1 year follow-up, and the effect size was quite large for this effect. And if you want to read more about this, this is published in Journal of Consulting in Clinical Psychology now. We also looked at eating disorder behaviors and cognitions, and in most instances, we found significant decreases from pre to post treatment. And then what I'm going to show you next is actually my favorite result. This is depression. So we see again significant large reductions from pre to post treatment in depression. So this was on the Beck Depression Inventory, and this actually went from the moderate to severe to mild range on the BDI, and this is in 10 sessions of treatment. And the reason I get so excited about this is because it's one thing if we work on the eating disorder, but we know everybody with an eating disorder has co-occurring disorders. They usually have depression, anxiety, personality disorders. And so we really want a treatment that can work on other types of mental disorders in addition to eating disorders. And this kind of suggests to me that this might be the kind of treatment that could be expanded outside of the eating disorders. Similar to worry, we had a moderate effect size here. And then clinical impairment was also significantly reduced from baseline to post-treatment. Okay, so what did we find? Summarize, we identified a lot of different treatment targets. This makes sense. 50% of individuals with eating disorders don't respond to traditional, on average, treatments. We found that transdiagnostic network-informed personalized treatment is feasible to implement. Patients like personalized treatment and they stick with it. And it reduces eating disorder symptoms, depression, worry, and clinical impairment. So our next step was to think about, well, how could we implement this with clinicians? Because, we're running these models, and this is in a graduate student training clinic, essentially, right? But what happens, can we take this out into the real world? And so what we did was we developed a software program that automatically, that patients report 5 times a day for 2 weeks on their symptoms, and then the program automatically outputs treatment targets and recommendations to a clinician. So you can see over here on the right what that would look like. We're working on a newer version now, so eventually these things are going to look nicer. But in this case, it might output and say you might want to work on binge eating and self-criticism with your patient. And then the patient the clinician has the option to walk through the sessions that we've developed to work on, for example, binge eating, or the clinician can say, oh, well, that's good to know that I should work on binge eating. I already know how to treat that, and I can use the treatments that I know work for that. So they can take our treatment recommendations, or they can take the results on what symptoms might be helpful to work on and use their clinician judgment and knowledge to work on those symptoms. So we tested this with a small sample with 5 patients and 5 clinicians. We had 98% compliance rate in terms of EMA data, and 100%, 5 out of 5 completed the entire pilot with very small sample size. But in general, what we found was the eating disorder specialized clinicians really liked the software application. They found it easy to use. They thought that it could help treat patients more quickly and efficiently. And patients also, in general, liked it. They didn't think it was quick, because it's not really super quick when you're answering questions 5 times a day. But other than that, they, in general, rated it pretty highly. So our next steps. So we're doing several different things right now. So we last September got a big NIH grant to test each of the different modules of treatment that we have, so that we can actually test whether or not we are targeting the things that we want to target. So, for example, if we're trying to treat guilt, are we actually treating guilt? We're also working on integrating social context into our models. So things like food insecurity, sexism, racism, poverty. Because if you have a patient and they don't know where their next meal is going to come from, it's very difficult to do regular eating with them, right? If they don't have enough food. So how do these sorts of social contexts impact eating disorder symptoms, and then how can we integrate them into treatment? We are also have just finished our randomized control trial on network informed treatment versus enhanced cognitive behavior therapy. We are cleaning the data set and we'll be analyzing that very soon. We're also continuing to improve upon our clinician guidance system, and then we're starting to think about if we can extend this type of treatment to other psychiatric illnesses like depression. Okay. Any questions before I move on to problem number 2 and number 3? And like I said, I'm happy to answer questions at the end too.
I do want to encourage questions as always. I think this is really rich, compelling data.
All right. Well, think about some questions for when I'm done. Okay. So going back to the beginning of the talk, I mentioned that there are 3 problems with eating disorder treatment. And we talked about problem 1, which is that treatments don't work for everyone. And now I'm going to talk about problem 2 and problem 3. So problem 2 is access. So only 20% of individuals with an eating disorder seek care. And on average, treatment is sought 10 to 15 years after illness onset. Wait times to access care are long, so data documents that median wait time for CBTE is 149 days. And this is a problem because the longer someone has to wait, the less likely they are to recover or to even decide to go to treatment. Most individuals have to travel out of their area to access care. So on average, usually folks have to travel about 44 miles to get treatment. A nice or not nice example of this is in my state, in Kentucky, there's only one eating disorder specialty center in Kentucky. So if you want care in Kentucky, you basically have to travel to where we are. Insurance often does not support care. So if you take a look at the mental health parity reports that are out there, most states score a D- or an F. I think there's one state that scores a C, 2 states that score a D-, and then the rest all get an F. So obviously there are lots of barriers to accessing care. So our solution for access is to work on digital treatments that can expand the reach for people who aren't able to access treatment. And we're working on lots of different types of digital treatments on my team. But today I'm going to be talking about just one of those. But if you go to our website, you can see examples of many others, and I'm happy to talk about those at the end too. Okay, so our third problem is relapse. I talked a little bit about how evidence-based treatments don't really work that well for eating disorders. And then in addition to that, we know that even after treatment, up to 60% of patients relapse, which leads to what we call the revolving door phenomena, where people are in and out of treatment, and sometimes will even end up living in treatment centers for years and years. So our first line evidence-based treatments are actually, they're pretty good at weight restoration, so they can get folks back up to the weight that they need to be at. But when you look at differences, when you look at the actual cognitive affective pathology that's left over after weight restoration, control treatments do not outperform our treatments, our evidence-based treatments. There's also no evidence-based treatments for relapse prevention. So all of this combined means there's lots of relapse happening, probably because there's a lot of cognitive pathology that's left over after weight restoration that isn't being targeted well by existing treatments. And we don't really have a relapse prevention treatment to deal with this. So what our solution is, both to access and to relapse, is to develop a digital treatment that can address unremitted cognitive pathology. And we really need a digital treatment so that we can deliver this after discharge from treatment. And ideally, when folks have been weight restored or are partially weight restored, so that we can address cognitive pathology. So the ideal time for this is really when they're discharging from a higher level of care. Okay, so let me talk about what unremitted cognitive pathology is. And in general, when we're talking about the eating disorders, most of this is anxiety. So up to 95% of individuals with an eating disorder have an anxiety disorder. We see all different types of eating disorder, of anxiety disorders in the eating disorders. And even if someone doesn't have a eating or an anxiety disorder, they have high anxiety. So this is things like fear of food, fears of weight gain, fears of physical sensation, lots and lots of eating disorder specific anxiety in addition to the other types of anxiety and OCD related disorders. So how do we treat anxiety? Anybody know this? If I'm a cognitive behavior therapist, because I know we've got lots of different types of clinicians on here, but if I'm a cognitive behavior therapist, how do I treat anxiety and OCD? This is where I miss in person. Okay, I'll tell you the answer. Exposure therapy. How many folks know what exposure therapy is? Well, I'll assume that we got 50% of folks who do and 50% who don't. Yay, we got a hand. Thank you. All right. So exposure therapy is the gold standard treatment for anxiety and OCD spectrum disorders. There's lots of different forms of exposure therapy. There's in vivo exposure for specific phobias. There is imaginal exposure for PTSD and OCD. There's exposure and response prevention for OCD. There's social exposures for social anxiety disorder. There's interoceptive exposure for panic disorder. And eating disorders are comorbid with everything and have a little bit of every type of anxiety. So a lot of the work that we've done on my team has been adapting exposure therapy from the anxiety disorders and OCD to the eating disorders. So one type of exposure therapy that I've been really interested in for a long time is imaginal exposure therapy. And this is used when the feared stimuli is difficult to recreate in real life. So a good example of this is OCD and catastrophic illness. If you have a patient with OCD in your office, you can't have them contract Ebola if that's what they're afraid of. Right. Number one, you can't just make them get sick. And number two, that would be pretty unethical to give them Ebola if you could. Right. So what you do if OCD is you do imaginal exposure, where you have them imagine that they're contracting an illness and sit with the anxiety that comes up and challenge their expectations around what they think is going to happen if they get this illness. This is what is used for OCD and PTSD. So similar to the example in OCD, many core fears in the eating disorders are difficult to recreate. So when you have a patient in your office, you can't have them rapidly gain weight in your office, right? You can't have them come in and gain 50 pounds. And you definitely can't have them gain 50 pounds and then have all of their friends and family reject and abandon them, right? Because they've gained weight. And this is what many, if not most people with eating disorders are really afraid of. I'm going to gain all this weight really quickly, and all these negative social things are going to happen to me because I've gained this weight. So when I started this work, only one case study had investigated imaginal exposure for eating disorders. So what my team did was we wanted to test is imaginal exposure an effective treatment for eating disorder symptoms and fears? And can we deliver imaginal exposure therapy in a digital format? There's lots of advantage of online interventions. We weren't fancy about this. We used REDCap, which is a university provided system that can do surveys, and now it can do all sorts of a little bit fancier things. But this is essentially what we did. We had people write about a specific fear and do this several different times, come up with an imaginal script, which I'm going to play you an example here of what an example of what people would.
I have gained weight over a short period of time, and it is noticeable. I feel disgusted with myself and worry about losing my fit and thin persona. I'm in the car on the way to work. I hate the way I fit into my clothes now. I can't believe I've allowed myself to gain weight. I look at myself in the mirror in the car. I look chubby. I can see my stomach bulge. I glance at my arms and long for the muscle I used to have. How will I walk into work? People will notice the weight gain right away. I pull into work and sigh. I know I have to go in and face the day.
So that is an example of an imaginal exposure script for eating disorders. And we did this with 100 we recruited 229 people, 167 started. And you can see we had 122 who went through all 4 online exposures, writing about their fear. And then we did post surveys in 6-month follow. So this here is change in eating disorder symptoms from pre-post to 6 months, from digital written exposure therapy. These are our data on eating disorder fears specifically. So we have anxiety about eating, food avoidance behaviors, which is how much they're avoiding foods, and fear concerns, which are our core beliefs, are things that we think are going to happen. I'm going to be judged, abandoned, etc., because of my eating disorder. And you can see we have significant decreases here. And these, again, are specific fears. So we have fear of weight gain, social fears, personal fears, physical sensation fears. So things like being afraid of your stomach feeling like it's bloating or your thighs rubbing together, and then social eating fears. And again, we saw significant change. Well, this is great, but this is an open series. And we want to know, well, what about, does this hold with a control condition, right? So feel very excited. I'm sharing with you hot off the press results here from our randomized control trial that we're currently writing up. So what we did here was we randomized participants to either digital written imaginal exposure therapy, or we randomized them to a control condition in which they wrote about their eating disorder. So this was, you can kind of think about it like journaling. They were journaling about their eating disorder for 4 sessions. And importantly, all of our participants that we recruited had recently discharged from treatment in this trial. So we're getting this sample that's coming directly out of treatment, and they're either getting exposure therapy or they're getting control condition. And we want to know, in this population, does imaginal exposure therapy outperform the control condition? And yes, it seems like it does. So what you see here is fear of weight gain, which is exactly what we want to target in 130 participants with an eating disorder, all within 3 months of discharge from treatment. And there is a significant difference between the control condition and the self-guided digital written exposure therapy. More to come on that. Okay, so we talked about how we need better access. We need personalized treatments. We need treatments targeted at anxiety and additional cognitive factors, and we need digital health solutions. And so hopefully this work has shown how we're starting to make progress in these areas to really improve how treatments work, to improve who's accessing treatment, and now also thinking about how we can use some of these digital interventions to prevent relapse. These are some of my collaborators and my team, who I couldn't do any of this work without. And I'm happy to answer questions or to talk more about any of the other sorts of work that's going on in my team as well. This is just a little bit of a sampling of what's happening.
Thank you, Doctor. This is really fascinating. And really incredible, really impressive research program. I mean, I do primarily clinical work, but this takes me back to, the graduate school days of research. So it's really wonderful to see.
Thank you.
If I may say, I totally agree as well. But, I love the fact that you're focusing in on personalized treatment and you're breaking it down to the different types of modalities that would work. And, I think that's true of all our clients. And although eating disorders hasn't been something I've specialized in, I've run across it a few times. And there was no question early on as a therapist that I felt if this wasn't my specialty, I could very well do more harm than good.
Absolutely.
So, what are you going to do with what you've learned as far as sharing it?
Yeah, that's a great question. I really like what you said about how you could do more harm than good, because, we see that a lot in the eating disorders where very well-intentioned folks can really prolong the eating disorder. And that's why I really love presenting to people who don't necessarily work with eating disorders, right? Because I think that you probably are working with eating disorders and maybe you just don't know it, right? Or you do know it, right?
As a secondary or something that they say
Yes.
they've had in the past, but it's not the reason why they say they come to therapy. But yes, you always have to be cognizant of it if it exists.
Absolutely. I had a clinician that worked at my clinic who was an OCD specialist, and he had been working with the patient for 2 years. And, he'd never really thought to ask about eating disorder symptoms. And then I got there and he started asking her about eating disorder symptoms. And it turned out she had a pretty severe eating disorder, but, it had never been asked about, right? But I do think that to your bigger question, I think that eating disorders are so common, and often people are really kind of reticent about treating eating disorders. And I think that the kind of work that we're doing, especially with our clinician guidance software, and we're working on a book now for personalized treatment. I think that that's going to help, that we can hopefully help people feel more comfortable about treating eating disorders, because it can help guide people through how to do it, and kind of break it down in a way that it doesn't seem like such a scary sort of illness to address. I also just think in general, thinking about personalized treatment, I feel like we've been so stuck and I mean, our treatments haven't really gotten better in the past 30 years, right? Like people get mad at me when I say this, but it's true. They haven't science-wise really gotten that much better. And I think now we've got all these new types of modeling, statistical modeling, and all these technologies. And I think we need to start thinking more out of the box about how we can do this. And to me, I mean, I'm a clinician. I see patients still. And to me, this is really kind of how I've always done treatment, right? It's like you have a patient and they have these different problems, and you have to figure out what am I going to do to help with this problem. And really, the goal here is to kind of help clinicians deal with that so they don't have to guess what should I do, right? But instead have guidance based on data. Oh, well, you could work on this, or you could work on this. And again, I could see this really expanding beyond eating disorders. And I'm hoping to put in a application to move into depression a little bit. So we'll see.
Well,
Did I answer your question?
You absolutely did. I also wanted to say, I really like the fact that you do bring OCD into this, because I think that's another area that we seem to be a little confused about. When you asked what would be like the treatment modalities for OCD, I have to say the first thing that came to my mind was medication.
Well, yeah, and we actually know that exposure and response prevention for OCD is one of our most effective treatments. So something like 94% of patients, if they're given exposure and response prevention, will really get better. And we can't say that for many illnesses. And the thing about OCD that's really interesting is it was thought of as a refractory illness, something that we can't treat, similar to how eating disorders have been thought of, until people figured out, hey, we can use exposure and response prevention, and this works really well. And that was it was actually, not to tell you my life story or anything, but when I was in graduate school, I was doing a practicum in an intensive OCD clinic, and we were learning how to do exposure and response prevention. And then my next year, I went to go do a practicum in an eating disorder clinic, and nobody was doing exposure and response prevention. And I'm listening to these people with eating disorders, and I'm like, this is OCD. Why aren't we doing any of this exposure and response prevention? And that is essentially when the exposure arm of my work was born.
Thank you. So it's all very interesting. I will
Thank
look
you.
into it.
Thank you, Cheri. I also want to express my respect and appreciation and admiration for the work you're doing, and especially the way in which you've developed an elegant research model and are struggling with, the application of that to the clinical challenges with these patients with eating disorders. I have a couple of questions,
Sure.
and I think they're both not ones I expect an answer to, but I'd be interested in you sharing your thoughts. And I'll start with the easy one, but neither of them is easy. So I have a lot of experience with eating disorders over 4 decades. Started the first vertically integrated eating disorder program at Northwestern University with Craig Johnson back in the early 80s.
Oh, amazing, amazing.
And beyond that. So I've seen hundreds, if not thousands, of eating disorder patients. What I've noticed over this last decade is the way in which many of these individuals are presenting as if they have medical conditions, which in my view are masking eating disorders and being framed as, I need to be gluten-free, I'm lactose intolerant, I'm allergic to sugar, I'm allergic to water, oxygen, etc. And so I'd be interested in, and most of these people are successful low weight restrictors. And that I think the prevalence of bulimia, it seems to be going down, at least in the ones who are presenting for treatment in our settings. So I've been interested in how you approach these individuals who are coming to treatment with a medical frame that seems impenetrable, at least for some of them.
Yeah.
How
No,
you think
that
about them
is,
for assessment and for treatment?
yeah, no, that is such a great question. And, I agree. I've seen so many cases like that. When I worked on the inpatient unit at UNC, I mean, I had a couple patients, but I can remember one woman in particular who had a BMI of like 13. Nobody could even believe that she was alive, right?
Right,
And
right.
the way that it started for her was she had she had a stomach ache, and she thought that she had some allergy or some gastrointestinal problem, and she just kind of stopped eating and got thinner and thinner and went to different medical doctor after medical doctor, and then eventually she ended up on an eating disorder inpatient unit, right? And she didn't think she had an eating disorder. I mean, she's on an eating disorder inpatient unit. She has a BMI of 13, but no eating disorder, right? And this is where I think it's so important to take this personalized approach with people, right? Because it depends on how severe the person is, what their medical status looks like, right? Because for her, like, I'm probably not going to be using exposure therapy with her. What she really needs to do is just medical rehabilitation at that point, right? Like, it doesn't even matter to fight with her about whether or not she has an eating disorder, right?
Right.
It matters that she's getting proper nutrition and she's not dehydrated. And at that point, the physician is really, then the nurses are really the most important providers for her, right? And that's where I talked a lot about the cognitive recovery. I mean, of course, we're not great at nutritional rehabilitation, but if we can get people into inpatient and residential, I'm always very impressed with how well we can get people weight restored. Um, and then it's really about monitoring the change in their cognitions, and when is the appropriate time to then start using some of these more cognitive effective treatments with patients. So actually, um, kind of getting at what you're asking about and what I'm talking about here. So everybody cross their fingers, because on February 24th, I have an R01 that's under review. And if this grant gets funded, we're going to be answering some of those questions that you're bringing up, which is, when do we apply these types of treatments and who can benefit from them most, right? And like, what sorts of things get in the way of treatments working well? So,
That relates to my second question.
All right.
So, now I've always worked in tertiary care settings, so I've worked with a skewed population. But I'm working with that population that's most at risk for the highest morbidity and mortality. So my experience with the eating disorder population is that these are the most stubborn, ferociously willful people, on earth, and that even those with multiple comorbidities, everything else, is going to move forward in treatment before the eating disorder enters, into the recovery process. And so your model targets these core cognitions, and for at least the more severe patients, those core cognitions, in our experience, are really the tip of an iceberg for all kinds of unconscious motivations, needs, that have become maladaptively structured,
Mhm.
serving really vital purposes. Um, you know, and so, I'd be interested in your thoughts about, and those unconscious motivations often have to do with recovery from trauma. Um, and so I'd be interested in how you think about that population where, what's cognitively available to them um, in terms of what they think motivates them, feeling, guilty about eating or, feeling not thin enough, whatever it may be, really is a cover story for the needs to recover from all kinds of traumatic and forced helplessness.
Absolutely. Yeah, and I think it's a great question. And that's actually one thing that I really like about these ideographic network models is that we can zero in on things like trauma and other sorts of things that might really be driving the eating disorder. And we can include that in what we assess. And, patients are not really good at knowing what's going to end up in their model, just like you said, right? Like they think, oh, it's going to be body dissatisfaction, or it's going to be that I don't want to eat this food in front of somebody. And then it turns out that it's actually shame. I mean, shame is our most common symptom that we find in eating disorders. And that's not something that we talk a lot about in eating disorders, right? We find trauma comes up a lot. We find worry comes up a lot. And these are not the things that we usually focus on eating disorder treatment. And I think it's very consistent with what you've observed in terms of it really is these deeper level things. And so a lot of that can come up in our ideographic models, which is helpful for the clinician to know, helpful for the patient to know. And then I think getting at your point, it's like, yeah, like we want to talk about anything but the eating disorder, right? And one really interesting finding, we did a relatively small open series, but with very ill folks with anorexia nervosa. And we did imaginal exposure in person with them. And we didn't talk about the eating disorder. We just talked about what they were afraid of. And we took their weight. And, one of the things that was really promising was we saw their weight go up when we weren't even talking about their weight. We were talking about what they were afraid of. And I think I agree with you, or I feel like we have to address these more core things, or we're not gonna really get better from the eating disorder. The other interesting thing that I'll say is that we have this big subpopulation of people who do our trials who have tried like all these other treatments before, and nothing has really worked for them. So they sign up for our trials. So we've got this like super sick population in our studies. And that is, I think, like you said, I don't think there's an answer. I think we really need to figure out how we could use these things to figure out how to really get at what we need to for that person at what stage of recovery, and how are we going to like put motivation into that. There's so much to do. I hope that those are sort of my thoughts on it, but I mean I agree with you completely. And those folks in acute settings are just, it's so hard, especially with the medical compromised and brain isn't working well, very hard.
Thank you.
Cheri, this is Bryn Jessup. I also work at Yellowbrick, and I have really appreciated your thoughtful and comprehensive overview of your research project and program. It's very helpful. It's very inspiring. It caused me to think about those cases where I feel like despite my best efforts over a long extended period of time with a lot of really good treatment, collegial support, and teamwork, I have nonetheless gone down in flames. And when I think about those cases, it's impossible for me to divorce the symptomatic expressions of disordered eating patterns from a family systems context. And I wonder if you would be willing to speak to that
Yeah.
and thoughts you have about extending your work
Yeah,
um,
that's a great
to
question.
treating the family system.
Yeah, so I'll say two things about that. One, those patients that like just don't seem to get better, that was when we were surveying clinicians about um, what they might use the software program for. One of the most common responses was, we want to use it for our patients that we've been seeing for 2 years and still are not getting better, and see if we're missing anything, right? And I think, the social context is so important, whether that's family, of origin, or partners. And all our trial, most of our trials have been with adults, although the exposure trial I showed you, we had adolescents in it as well. And I don't have a good answer for you yet, except that we are thinking about how social context is so important, and um, how do we integrate that in. We have thought about maybe using some of the stuff that we're doing to build kind of a family support um, system. Um, Sort of similar to what we see with FBT, but very tailored, right? Um, so yeah, I mean, my answer is, we don't have a good answer, and we know that social context is so important, which is why we're starting to do what I talked about in our pioneer study, where we think about the social context and we're trying to figure out how do we integrate that in to the treatment that we're doing.
Thank you. I appreciate that. Enlarging the social context enlarges and complicates the clinical picture. On the one hand, on the other hand, of course, it enlarges the scope of possibilities for intervention and for
Absolutely.
changing longstanding patterns. But thank you very much.
Thank you.
But then what do you do when you open yourself up to other family members that have eating disorders? Quite often, they learn it from a parent.
Yep. Yep. I was actually having this conversation with one of my grad students the other day, just about how little we know on how parental behavior influences eating disorder behaviors. So one of our RO1s were following kids from age 6 to 12, and we're getting mothers and fathers or other partners to report on their own eating disorder behaviors, and then we're also following the kids. So hopefully from that, we'll be able to know a little bit more about how those interactions happen. But I mean, clinically, it's just that is so hard. I mean, I think some of my biggest frustrations as a clinician have been when I'm making really good progress with a kid, and then a parent comes in and completely derails it, right? And one thing that brings up for me is, one thing that we're working a lot on my team, is the social context that we're all in, which is where we live in a diet culture. We live in a world that has rampant weight stigma. And parents are learning that from society, and then that's getting passed down to their kids. And I think that our best bet for dismantling some of that is working more on the system levels to really change the way society thinks about bodies and thinks about eating and thinks about what health is. And we certainly have a lot of work to do in that arena, but otherwise people are just going to continue to pass it down, right?
And it's quite a delicate balance too, when you're working with someone and you're progressing, and then you bring the family in only to learn that they're not wanting you to work with them.
Absolutely.
You do you in a sense, betray the parent by discussing with the child how this is, or the young adult, how there's another way to look at this? Or
we do a lot of psychoeducation on weight stigma and diet culture, and that weight does not equal health, with kids, but also with parents and other family members. So, I mean, that's really how we try to get everybody on the same page. One thing that I find is really helpful is to make sure you have a pediatrician or several pediatricians who really understand diet culture and weight stigma, so that they can back you up and say to parents, no, like your kid really needs to gain 25 pounds, and that's not going to make them unhealthy, right? Because then when they're hearing that from multiple voices, that can maybe start to lead to some cognitive change for parents and for kiddos. So yeah, I mean, and this is one thing I tell all my trainees, is that not only are we treating an eating disorder, we're treating diet culture too. So we have to treat the eating disorder, and we also have to treat diet culture, which means talking to the parents, talking to the siblings, talking to their teachers, making sure that everybody understands that these things that you believe about weight are not actually based in scientific evidence or true, right? So,
and I also find with young adults, or adults, excuse me, is that part of their eating disorder is based on them saying they're eating healthy.
yep. And that, again, that's a diet culture thing, right? So if I eat vegetables and salads, and I don't eat any carbs, then I'm going to be healthy. But that is absolutely not true, right? Like, you need to eat all sorts of different foods. You need to eat enough food to fuel yourself, especially kids. I mean, and young adults, brains are still developing until age 25, right? And if you're not feeding yourself enough, your brain isn't going to develop properly. So it's absolutely not healthy to only give yourself healthy foods, right? We do a lot of talking about that.
I was going to say, for me, one of the challenges, the number of young people I've worked with that reference various online social network platforms that are actually designed to instruct, to encourage, to reward disordered eating, and really give a language around how to talk about this without letting people know that you are intentionally not eating, or putting up, this is the sign of beauty. I mean, there is that whole online culture that is actually really intentionally working against all that you've been describing tonight. And I think that many of us try to counter, but it is a powerful thing when somebody can pick up their phone and say, no, this says I'm okay.
Yep.
And so I know you didn't directly address that in your talk tonight, but I'm wondering with you and with others, how often do you hit that obstacle in the treatment process where you're arguing
100%
against?
of the time. 100% of the time. And that's, so one of the main things that we're adding into our treatment is assessment of diet culture and weight stigma. And we've developed a whole module on dismantling diet culture and weight stigma. And social media, what I'll do with kids and young adults is I'll sit down with them on their phone and talk about what should you unfollow, and maybe let's look for some other influencers that might actually be more positive for your body image and your health and your eating disorder, right? Because there's also lots of great people out there to follow that give messages that we want them to hear, right? But you have to look for them, and you have to know who to look for, right? But I think that I think that is a goal that you can set in treatment, is how can we get rid of these things on your social media that are causing you harm, right? Like you like helping them understand how it's causing them harm. And then how about we look at these things that might actually be helpful for your self-worth and your body image, right? And really working with them to figure out how they can modify their social media so that it isn't actively harmful for them.
I think your digital presence is brilliant. I think that has to be so helpful in the treatment. Are you finding that?
So that's not something we've explicitly tested. Sorry, what do you mean, like the tailoring, what I was just talking about? Yeah, no, that's something that we do clinically, but I don't think we haven't tested that empirically yet. So now you've just given me, another study idea to go
And,
do.
and I think earlier you showed how you sent messages through the song. That I think is just brilliant. I mean, I think that's so necessary.
Yeah. Well, and that's one other thing that we're working on is a just-in-time intervention for restriction. So we're using passive sensing to alert like when a restrictive episode might be coming up. And then what we do is what you're mentioning is where we send messages and skills directly to the phone to help the patient refrain from engaging in behaviors that are going to be harmful for them.
Yeah, and not feeling alone in the process.
Yes, absolutely.
So what kind of passive signs do you pick up on? It's interesting.
Yeah, so we collect electrodermal activity, heart rate variability, acceleration, and temperature, and we're building machine learning algorithms with those. So right now we are working on, we have a paper under review where we were able to predict restriction with like 92% accuracy, and we're working on replicating those models in one of our R01s. And then what we want to do is we actually, like tomorrow, this grant is going in where we're trying to develop those skills for restrictive behaviors. And then what we'll ultimately end up do is pairing that with the passive sensing. So hopefully it could like go to Apple Watch or something like that.
All right, it's time for us to stop for today. Thank you, Dr. Levinson. This was really fascinating and illuminating, and I wish you the best in getting your next grant.
Yeah, that's what I was going to say. I was going to ask you, how concerned are you about keeping up with your grants?
Very concerned. It's been a hard 3 weeks. We had a diversity supplement that was already canceled. I mean, thankfully these things are being held up in the court, but any of these cuts will significantly dismantle the work that we're able to do. And 15 years that I've been building up my team, and it's just feels like it's being attacked on a daily basis. So I appreciate any calls to legislators and things that you all can do. Science is under attack, and for me, it's always been about trying to make there be less suffering from eating disorders, and it just kind of feels a little surreal to me that like I've spent 15 years trying to make the world a better place, and there's people who are telling me that I shouldn't be doing this.
Just save your data, put it in a nice, safe place.
Oh, it's all backed up. It's all backed up. Absolutely, absolutely. Yeah. But I appreciate that question, and I'm telling my trainees and I'm telling myself, we just have to focus on the work, and that's all we can do is show up every day and do the work, and that is an act of resistance. And we just have to keep in mind that the work is the most important thing, and we will do it the best that we can. So.
And thank you.
Okay, thanks again. And once again, everyone, there'll be the video recording on our website in about a week. And also, please feel free to email us for a copy of Dr. Levinson's slides, and we'll be glad to pass those along.
Thank you all for having me.
Thank you very much.
Bye.
That was
Take care.
excellent. Thank you.
Thanks.
Have a good night, everyone.
Thank you.